Okay, chapter 29, anxiety and depression. This is part of your review again. Um, let's see where we're at here. This is something that a lot of times in primary care you're going to send them off to psychiatry if you can. A lot of people won't have the funds or the insurance to do so, so you kind of do have to manage some depression and anxiety. Gets into some kind of some complex issues because psychiatrists mix and match drugs a lot where primary care doesn't, and the anxiety issue is always you end up over prescribing when you really don't want to. So in the introduction, you have depression and anxiety, the patho, the meds, the pharmacodynamics, all of that good stuff. Let's get down to the nuts and bolts here. And I think we know about what the anatomy is. You can read that. Okay. So when you're prescribing something, especially for somebody that you're prescribing for anxiety, we make a lot of big mistakes. We think the patient is a little better, but that's like a great outcome, and that's not the case if they're a little better. So the biggest common mistake as practitioners we make is thinking that a partial response to medication is acceptable, and it's not. And I think you all know why I'm telling you this, because you must need to know this really very soon. Sorry I keep scrolling through this. This is like not getting me anywhere where I want to be. Anyway, okay. So appropriate first-line drugs for mild to moderate generalized anxiety disorder would be Buspar. Most people, I have seen it a few times, but we really don't use it all that often. But it is actually technically, and it really is, the first-line drug for mild to moderate anxiety. So Buspirone or Buspar. Let me see if I can find it on the slide here. Did I go through the anxiety meds and just like miss them? No, I did not. Okay, so anyway, let's go down. Anxiety, where are you? Alright. Oh, here we go. We can start here too, though. Okay, so you're going to treat. You're just not going to give Xanax or Valium. You're actually going to treat with a drug called Buspar. The Xanax, the Valium, all of that, it's all short term. Okay. So if you want to treat a panic disorder, the first line is diazepam. So first line for a panic disorder is diazepam. Not Buspar, not Elavil, or not Xanax, but it actually is Valium then for panic disorder, not just anxiety. So you have somebody who comes in and they're kind of thinking they're depressed and they want to know. Here we go. Here's your anxiety drug. They want to start on an antidepressant. They think they're ready. What do you think the first thing that you should do should you do any kind of laboratory testing? A lot of times, especially in the elders, actually it's just plain old hypothyroidism. So you always want to check thyroid functions on anybody who comes in with depression. Everybody. And here once again is Buspar, first line for mild to moderate anxiety. We all know what in red means. Remember, partial responses are not acceptable. That means you need to add another drug or do something like to manage the anxiety. So you're going to test your patient for hypothyroidism, and that isn't it. So then you're ready to go ahead and start them on an antidepressant. And usually now they're SSRIs or SNRIs. So SSRIs, especially in guys, they'll come to you and they'll be started on an antidepressant, an SSRI, and you need to educate them that they may experience sexual dysfunction beginning a month after the therapy starts. That's the prime time. Okay, so remember on all the tests, they want you to educate your patient. So you're going to have somebody who comes in and say you're going to start them on Celexa, so that's citalopram. And what are you going to tell them about their SSRI and how it's going to work? What can they expect? So you're always going to tell them that it's going to take a few weeks for them to feel anything. But in the first 1 to 2 weeks, they're going to notice a difference in their appetite and concentration. Those will both improve within the first 1 to 2 weeks. But the actual effect of the medication really doesn't take full effect until 2 to 4 weeks. So you want to make sure you always tell your patients that you're giving them this drug and it may not work. I've had people come in and with anxiety, and I don't use Buspar because I usually use Lexapro in the younger group, just 10 milligrams of Lexapro. And a lot of times I've had some people that are so anxious that I'll actually give just a small prescription of Xanax, just 0.25, 30 pills, until the Lexapro starts to help. So if you have people that come for depression and anxiety, and of course they tell you to use Buspar, but then I just was telling you too, escitalopram is Lexapro. So you need to know about that as well. It does treat depression and anxiety, Lexapro. Once again, on this test, it looks like both trade name and generic name are, are listed on the boards. You're going to have both names, at least in ANCC. If you're going to treat depression with fatigue and low energy, Effexor is a great drug. You can really max Effexor out pretty much to high limits. It works really well. Effexor tends to be really very expensive though, so you can always help your patient find those coupons online. Even Target and CVS have those. So if you have somebody on an SSRI, do you need to monitor anything as far as labs go? Do you need to monitor glucose, blood count, anything? Nope. So you do not need to monitor any no laboratory testing is required when you have patients on SSRIs. And let's see. So you have somebody on Lexapro. It's been on it for quite a while, and he wants to come off. So you have to taper any kind of SSRI. So always you're going to reduce the dose by 50% for 3 to 4 days. Really, any drug that you're weaning off, it's 50% for 4 days, every 4th day pretty much. You reduce by half, and then 4 days later you'll reduce by half, and on until you're off. That's the best way. So the answer is reduce the dose by 50% for 3 to 4 days. That's pretty much what you need to know about Chapter 29. It's good information, but it's pretty much, I think, pretty basic, and you probably have seen more in clinical practice than even what was on that PowerPoint.